this lecture, which sends a wild hair up the back of my neck when people say, hey doc, I have something called leaky gut. I'm like, you have what? You have leaky gut? There is no diagnosis called leaky gut, but man, you would never know that by looking at looking at the internet. Leaky gut, the correct term for this is actually called intestinal permeability diseases. And by permeability, I mean your intestine should not be permeated by things like sodium or bacteria or food particles. It should be a barrier. And when the barrier is broken, we call this intestinal permeability diseases. There have been a ton of people with leaky gut syndrome saying, hey, this is the cause of it, this is the effect of it. I will tell you, I have looked into this in many ways, and it is not easy to actually restore the permeability barrier. So making that intestinal impermeable is not easy to restore once they have proven intestinal permeability disease, which if you want to call leaky gut, okay, you're on your own. But I call it intestinal permeability disease because that actually means something. What's going on with these folks is they have defective tight junctions. Yeah, I'm going to geek out just a little bit. They have elevated pro-inflammatory cytokines, specifically TNF-alpha and specifically that INL-13, which is highly expressed in my folks with chronic inflamed intestines. What happens to them is they will start shedding cells from the insides of their gut, and they will have little bitty micro erosions called ulcers. This is a loss of barrier, and they are really sick people. They are some of the sickest people in my clinic. When I look at leaky gut, I use this list to say, what do we have associated with these intestinal permeability diseases? And they are obesity related, specifically when they have NASH or non-alcoholic steatohepatitis. When we have type 1 or type 2 heart disease, type 1 or type 2 diabetes, when we have cardiovascular heart disease, Crohn's disease, ulcerative colitis, rheumatoid arthritis. You'll see lots of autoimmune problems here. You'll see lots of mitochondrial diseases like lupus or, multiple sclerosis or autism, linked to mitochondria that aren't working right. The list is much longer, but I like to point these out for those who say, could this be linked to my leaky gut? And I'm saying, we know that it's linked to your leaky gut, especially if you're talking about intestinal permeability defects. The problem is that we have yet to be able to say, does anything restore the barrier of the intestines once it's gone bad? And I like to point out in this study where they said, yes, we have looked into this, we have studied permeability, and we know that a compromised intestinal barrier function is associated with an array of clinical conditions, both intestinal and systemic, meaning, yes, this has to do with your gut, but it also has to do with your brain and your heart and your endocrine system. We also know that these folks use this word leaky gut syndrome, and the correlation between the intestinal permeability, meaning the leakiness of the gut, and disease has caught the attention of the public and is leading to a rise in popularity of people using the term leaky gut syndrome, which encompasses a range of symptoms. It's not just a leaky gut that we should be focused on. There's much more going on here. Here's the problem. Although we have drugs that target and try to mediate the barrier restoration, they try to seal that gut back up. None of these drugs that I can prescribe have proven to be effective. All right, so here's this silly word, leaky gut. I'm going to replace it with intestinal permeability. I'm going to point out two of the toughest places, two of the sickest places are folks with Crohn's disease and ulcerative colitis. All right, attempts to modulate the intestinal permeability. All right, we have a lot of things that we've tried to do. We've tried probiotics, we've tried prebiotics, we've tried giving these patients colostrum, which is, again, breast milk from the first few days the mom is breastfeeding. We've tried taking somebody's poop and putting it into another person called fecal transplants. That is a fun one to talk about. There's something called a FODMAP diet, and we've talked about the paleo diet. Keeping in mind, this is not PKD. And you're going to know what that means here in just a second. The problem with all of these attempts to modulate the intestinal permeability, they have all failed when it comes to actual evidence of improving the intestinal permeability. We know that, especially the paleo diet, the one that is not quite a low carb or a ketogenic, or it's a low carb, but it's not quite a ketogenic diet. They have done a lot of studies, and there have been some associated improvements in how the patients feel. However, when measuring their intestinal permeability, zero, did not improve their intestinal permeability until now. And I want you to carefully read this title. It says, Crohn's disease successfully treated with the Paleolithic Ketogenic Diet. And I'm going to give a big hats off to Sophia Clemens, who has been my teacher from across the globe. She is out of Poland and has just an incredible wealth of knowledge. And we're going to use some of her data today as a way I want to make sure to give full attributions for her clinic and what she's doing to give evidence that the worst of the worst patients, the sickest ones in my clinic, have been improved when they follow a Paleolithic ketogenic diet. All right, we're going to go through these words here. Paleolithic ketogenic diet is not a paleo diet. It is a Paleolithic ketogenic diet. All right, so that stands for PKD. PKD is ketogenic, meaning they are having high ketones. You could measure their Dr. Boz ratio. They'd probably all be 40 or less in their numbers. And it's also Paleolithic, meaning there is no or very limited vegetables. There are no fruits. There are no vegetable oils. There are no seed oils. And more importantly, no supplements, no vitamins, no herbs, it does not actually, this is not talking about ketone supplements. It's just saying there are no extra supplements of vitamins or anything else going into that gut. Only what was going in are the Paleolithic things of vegetable oils, fruits, no vegetable oils, no seed oils, no fruits, no vegetables, and no supplements. The studies you're about to see did not use ketones in a can or ketones supplements either. They simply used a Paleolithic ketogenic diet. Okay, so that I'm about to give this lecture to the obstetrics and gynecology, the only thing I can tell you about your audience of moms is we do have pictures of babies born to moms on the Paleolithic ketogenic diet. So stay tuned. This is who I'm trying to help, saying, remember, this is not a paleo diet. It's a PKD. All right, before I lose my audience, I'm going to go back to histology. This is the study of cells. This is supposed to be the cell lining of your gut. So that part on the top that's white is you seeing, that's where the food goes. That's where our food comes in one end, goes out the other. That little blue area is supposed to be the slime layer that we all have protecting our body. And then the rest of these are the cells of enterocytes. We have Paneth cells that make digestive enzymes. We have goblet cells that make the mucus or the slime layer. We have the nerves that keep track of how things are moving along, and they're called dendritic cells. And more importantly, we have this thing called the lamina propria, which is where our defense system hangs out. These are plasma cells. We also have extra plasma cells that God put in between these cells called intraepithelial plasma cells. Again, we are trying to protect from anybody trying to come to the inside of the body from the outside of the body as foreign objects come in when they shouldn't. And then the final little layer that God added to every one of these are the staples, and I mean tight junctions. See these little staples at the top of each cell? These are the final defense layer that says we are not going to let anything into this. We are not going to let impermeability, we are having impermeability. Nothing permeates these junctions because we have tight junctions followed by plasma cells, followed by a lamina propria. We have layers to protect us from anything getting in that shouldn't. So the problem is when we have intestinal permeability, there are 4 phases. So watch what happens when I push this clicker and we go from, and phase 1 shows up. Ready? Here we go. Notice that these spaces between the cells are now microscopic at best, but they are there. And unfortunately, what happens when these microscopic layers are there is these tight junctions get stressed. They get stretched out a little, and now they let through some small little salts or sodium solutes. It's super tiny. It's not a big deal. We sure as heck can't measure it with an X-ray or a CAT scan or even an ultrasound or a colonoscopy, we can't see it happening. It's super tiny, but it is there, rest assured. And those salt solutes are the only thing that gets through it first. But then comes phase 2. And phase 2 has even more space between these cells. Now the cellular separation becomes a little more visible, again, not by the naked eye, but we can see it on a microscopic level. Our stretch of our staples are now just barely holding on to either edge. And unfortunately, they're starting to let in foreign particles. These are little particles of food or foreign objects that come in. And once they're there, they can actually go both ways, but more importantly, they got past our intraepithelial plasma cell, and now that little fella will trigger a plasma cell to come over. The plasma cell will then activate. It switches from a kind of dormant phase to one that is producing some things called cytokines. And the cytokine that comes out when food particles come in is we can measure that the interleukin 13 is higher. You might remember that I mentioned that earlier as one of the bad boys. Interleukin 13 is a cytokine, and it comes from activated plasma cells in many areas, but specifically when food particles get into your lamina propria, your interleukin 13 will now modulate cell death. It's supposed to modulate tumor cell growth. It also is supposed to help you watch for new cancer cells, like it monitors for new cancer antibodies, and the potent mediator of fibrosis. So when interleukin 13 is a little bit, we can see that it's going to kill off the bad cells. It's going to watch for a few more cancer cells. But the longer that's around, it turns our beautiful, soft lamina propria into something that's very fibrous. That is not good for your guts. The extracellular matrix is also another key regulator of interleukin 13. All right, so let's go back. We're at phase 3, and now phase 3 has even wider separations between these cells. And we look at those staples, and there is some that don't fit anymore and others that really don't do a good job. But more importantly, we have things like macromolecules, we have food particles and antigens, and we have bacteria now that can slip through those cells, get into the inside of our lamina propria, and then activate our plasma cells. The other thing that's happening is we see things start to leak out, like we lose a lot of vitamins and a lot of magnesium and other solutes that are going out during phase 3. So sometimes we can't notice what's going on at a cellular level, but we can start to see that the body is depleted of things like iron and vitamin D when the gut is leaking. Once that activated plasma cell happens from these types of antigens, we get tumor necrosis factor alpha present. Again, this cytokine is one of the bad boys. It is one of those that does a really gnarly job when in excess. So in little amounts, the TNF alpha does the regulation of your immune system. It's what causes you to have a fever. It is what signals us to use protein in the muscles as food sources if we need them. It is linked to a bunch of inflammation. It is also what's supposed to stop tumors from generating. It's supposed to cause or initiate that programmed cell death. But that's what happens in tiny doses of TNF alpha. If there's a dysregulation of TNF alpha, we know that it's linked to Alzheimer's disease, to cancer, to major depression, to psoriasis, to inflammatory bowel disease. These are just a few, but they are signs of some of my sickest, most difficult patients to take care of. So, phase 4. Here we go. What happens in phase 4 is those little staples, they are goners. They start to fall off and they disappear. Now the staple guns at the top of the cell are gone, and unfortunately the cytokines start coming out in masses because those plasma cells, there's an army of them turning on, making cytokines, and before you know it, we've got cells disappearing. They're causing programmed cell death of our lining. The Paneth cells disappear, some of the goblet cells disappear, other intraepithelial cells disappear. And what we end up with is exposure, just a raw exposure of the lamina propria. And the word we use when we look, the dendritic cells are also on fire. The population of these excessive cytokines become something we can see abundance showing up of once you start to have ulcers in that area. And that is what this is called. When we have the removal or the destruction of those enterocytes, we now have a barrier that just spews out not just nutrients like vitamins and minerals and proteins, but also that it allows a whole host of things to come into that body that should not be there. Again, these are...
Please subscribe to my channel. And don't forget to click the notification bell so you don't miss out on any new videos. Stay tuned.